I was walking through the fixed department today and I saw this case, an interesting one of the more challenging ones that any of us probably have to deal with. Certainly one of the more challenging ones for the laboratory. It's the single central incisor. It's a toughie. The dentist did a pretty good job with the impression. As I look around on the facial, I can actually see the margin there. It looks like a little of the stone broke off. And easy to see on the lingual. Little tight there interproximally. We'll have to see when that gets trimmed. How clear we can see it there or not. Interesting. We can really see it on the facial and lingual. We lose a little there. Looks to be nice reduction. Let's look at the mounted models. I keep wanting to turn them over. They look upside down because of this class 3 bite. The centrals are edge to edge. And the lateral incisors are in a class 3 relationship to the lower anterior teeth. He gave us enough reduction, which is nice, on tooth number 8. And he has prescribed a single unit crown here. Now, my first choice for a crown like this is going to be e.max. e.max gives us the best chance of giving you a restoration that's going to match the adjacent tooth because of its aesthetics. It's got enough strength to do very well on the anterior, but on a patient who's got an edge-to-edge bite like this, when a dentist prescribes Bruxer, as this dentist did, I agree with that too, and I have no problem with that. It's just going to be a little more challenging to make that crown match the adjacent tooth. In fact, one of the things that I find really helpful in cases like this is to do a no-prep veneer on the tooth next to it. And, you know, I learned this in an interesting way. You know, since I practice inside of Glidewell Laboratories, I get all my restorations for free, as well as a hot lunch every day. And when I got restorations for free, it became clear that all of a sudden I could do certain things. Like if I was doing a single unit crown on a tooth like this, I could also ask the technician for a no-prep veneer on this tooth. And oftentimes I would try in this crown and the patient, I would look at it and we'd say, yeah, it looks okay. And then I'd say, wait, let me try something. And I'd put the no prep veneer on this tooth and we'd look again and the patient would say, wow, that looks a lot better. What did you do? And because now these two teeth match all of a sudden. Then I started doing it the other way where I would try in, I say, let's go ahead and take a look at that. And I'd put in the crown and the no prep veneer without saying anything and give the patient the mirror. And they'd say, wow, that really matches well. That looks great. And apparently they'd forgotten what that tooth looked like because now they just loved how much those two teeth looked next to each other. And they say, that really looks good. And I say, okay. And I say, let me hold on a second. And I'd go in there and I'd take this one out. I'd take out the no prep veneer and leave the crown. And I'd say, go ahead and look one more time. And they'd look and they'd say, oh, now what happened? I'd say, well, actually, here's what I did. We made a veneer for this tooth. And I thought of it after you were here and I just had to make it because I wasn't sure if you'd like it or not. So if you want to, we can put it in, but if you don't want to, we don't have to put it in. And so, because obviously there's no shots or drilling or anything at this point besides luting it on, and the fact that it almost always makes that tooth disappear, or at least, you know, assures that it's going to match this one because they're both made at the same time from the same material, 9 out of 10 patients said yes to it. You know, sometimes if we were doing 2 teeth, I would make no preps for these two. Sometimes it would just be for the bicuspids if it was a case where we lost the buccal corridor because it had been restored to the cuspids previously or something like that. But jokingly, when dentists ask me what's the best way to restore successfully a single central incisor, my answer is to put a no-prep veneer on the one next to it. But that wasn't done in this case. It wasn't presented to the patient, although it would be fun just to make one for this doctor and send it along for free and give him a heads up and see, have him report back and see how it does when he tries that into the mouth. So in order for us to make a crown, certainly a Bruxer crown, but even an e.max crown that's going to match the tooth next to it, we're going to need a photograph. There's really just no way. I mean, just imagine that you're the technician trying to fabricate this crown and the shade on this is a D2. So we've got a D2 and that's really all we have. We have an impression of this tooth, and really, so we're just going to do a D2 and kind of match the shade guide and assume that's going to be able to blend in with this. So we're going to need some photography, and the dentist actually sent in some photography, which is a great step in the right direction. And so again, you can see how our centrals are edge to edge, our laterals are in crossbite, and you can see how the tooth number 8 has fractured already, possibly, potentially, because of that edge to edge relationship. And so here's tooth number 9 still edge to edge, and so a bruxer crown there I don't have an issue with. The problem is this dentist owns a camera. That's not the problem. But he took a photograph that's essentially useless to us or useless to our technicians because there's not a shade tab in place. And so the variability in color from camera to camera and printer to printer if it's not emailed, or even monitor to monitor if it is emailed, there's so much variability that without a shade tab in place to compare the shade of tooth number 9 to, unfortunately this picture, while it might be useful for something having to do with surface texture or some other sort of characterization, it doesn't help with shade at all because we need a reference. A D2 shade guy would be nice. We'd prefer to see the shade tab with the patient open. He did take a picture. It's slightly blurry, so we're not going to be able to get that one in focus, but with the patient open like this, we would take a shade tab and we would put the incisal edge of the shade tab up against the incisal edge of the tooth in the same plane, so we wouldn't want the shade tab towards the uvula or out in front of the tooth. We want it incisal edge to the incisal edge in the same plane so that when the flash hits both of these, it's going to hit it just as hard. So in the same plane, incisal edge to incisal edge, make sure you don't cover up the D2 or the A2 with your thumb. That's another one we see about 10% of the time is the doctor is conscientious enough to take a photograph with a shade tab in place and then covers up the name of the shade tab with his thumb, or the assistant does, and then it's kind of difficult as well unless we can call them and they remember what it was. So with a shade tab in place, even if it's a D2 and it doesn't really match, what it allows us to do is now we can see the shade of the tooth and the shade of the D2 in the photograph and see the relationship between the two. So they might look at it and say, the tooth is not quite as gray as the D2 and the value is actually a little bit higher. So then when our technician is making the bruxer crown, they will take a D2 shade tab out as they're doing the staining and glazing and continue to match it to the D2 and go, okay, I need it to be a little less gray than this with the value a little bit higher, and get that same relationship between the crown here and the D2 shade tab here as we have here. Otherwise, this really doesn't do anything for us about where it is, and the chances of this being a dead-on D2 are just not that likely. So this doctor did such a great job of doing a good prep, reducing enough on the incisal edge, reducing enough everywhere, getting a good impression with the margins, and actually taking pictures. The only thing that's missing is the fact that we don't have a shade tab in here as well. So I'm going to call the doctor and tell him we can go ahead and proceed with the crown at this point, but if I had to put a number on it, I'm going to say there's maybe a 50 to 60% chance that if we just made the crown now, that the patient would like it enough to be able to cement it. But I believe if he were to get the patient back and get a photograph with a shade tab in place, those odds are going to go up to 85 to 95% that we're going to be able to match the shade well enough that the patient's going to be happy with it and be able to cement the crown that day and be done with it. Of course, we could also do the no prep veneer on the one next to it too, if he's interested, which I do like to do, although I can see, it's something to bring up to patients and ask them about that if they want to. Again, keep in mind that most of the teeth that we restore, because we as dentists have a tendency to under-prepare teeth because we're conservative, especially on the facial, like on these anterior teeth, since we have a tendency to under-prepare and technicians have a tendency to overbuild in the name of aesthetics, teeth have a tendency to grow. And it's pretty predictable, almost 85% of the time in the last study that we did, when we measure teeth after they have a crown put on and then measure it using CAD/CAM technology against a scan of the original tooth before it was prepped. So for example, if we took a impression of this central incisor of tooth number 8 here, and we took an impression, poured it up, put it in a scanner, and then measured the facial lingual thickness, and then the doctor prepped it, and the crown was cemented into place. We took another impression, poured it up, scanned the crown. The facial lingual thickness of the crown here, on average, would be 0.2 of a millimeter thicker, 2 to 3/10 thicker than the original tooth. And it would all be on the facial. It can't grow to the mesial or the distal, and it can't grow to the lingual. And that's why a 0.3 of a millimeter no prep veneer on the adjacent tooth looks so good next to a tooth that's been restored with a crown, because the crown will usually increase in size on the facial surface by 0.3 of a millimeter. So not only does the shade now exactly the same between these two teeth, but now the tooth that's been restored with a crown doesn't look too bulky, too fat on the facial, because now both of them have been increased by 0.3 of a millimeter, and they both match now in terms of size and contour and shape as well, making it even easier to get these two teeth to match and for the patient to like the restorative result.